Uh, Hello, good morning everybody. Dear coordinator of the ISFTH TeleNursing Working Group, Konstantinos Antipas. Dear invited speakers, nurses. Now, for this session we have two invited speakers, the nurses Dr. Rebecca Bates and Dr. Patricia Camilo. Dear ISFTH affiliated members, colleagues and partners, good morning or good afternoon. On behalf of the ISFTH, I would like to welcome all of you to the first webinar organized by our society in this year. So this is the first session in 2019. Today, the very special theme of this webinar will be telenursing in advanced practice nursing, a session that will be moderated by the coordinator of the ISFTH TeleNursing Working Group, Konstantinos Antipas from Norway. At this moment, I just would like to inform that the session transmitted through this AnyMeeting platform, the entire session will be recorded. So the content of slideshow and respective audio will be available to those colleagues that for some reason couldn't attend the live session today. The access link to the recorded session will be informed in around 24 hours and will be posted on the ISFTH website. During the webinar, a chat box will be available on the left side of the screen, so your comments and questions are quite welcome. And at the end of the presentations, Mr. Konstantinos, the moderator of the session, will open a time interval of around 10 or 15 minutes for questions, and a round of discussions is expected to be held with the active participation of the audience. So please use the chat box for that. Before going through the outstanding topics and presentations of the session, it's my mission and honor to say some brief words about the International Society for Telemedicine and eHealth, mainly directed to the audience that is not yet familiar to the ISFTH. So the first slide is about our society, the ISFTH mission. In fact, the International Society for Telemedicine and eHealth exists to facilitate the international dissemination of knowledge and experience in telemedicine and eHealth, and to provide access to recognized experts in the field. So the ISFTH headquarters is located in Basel, Switzerland, and is a non-governmental organization and non-profit that is in official relations with the World Health Organization. Let me see if I have the next slide. A little bit slow from my side. Just waiting. If we can move to the next slide. Yes. So in order to achieve its objectives, the International Society for Telemedicine counts on several working groups that are active at this moment, including students, telenursing, education, several others, telecardiology, teledentistry. So if you are interested in joining ISFTH and participating of the activities of the working groups, you are all quite welcome. In order to achieve its objectives, also the society organizes an annual international conference. In this year, the conference was held in Lisbon with the participation of around 15,000 people. So that was really a very impressive and outstanding meeting in Portugal. In the next year, the conference will be held in Japan, in the city of Takasaki, in October. So the conference, under the acronym of Connecting People with Telemedicine, is expecting to be a very interesting meeting in Japan. So you are all invited to participate in October 2020. So the society also organized, like today, a series of webinars. In the last 10, 15 years, so many webinars were held in different countries like Russia, Australia, Argentina, and in Luxembourg during the period of Meditel conference. And we still continue with the webinars like today. Also, members of the ISEFTH have other activities that can participate, like the newsletter that is quarterly available, and also we have the Journal of the International Society for Telemedicine and Health that is currently published and coordinated by Dr. Maurice Mars from South Africa, also in conjunction with Professor Malina Jordanova and Professor Richard Scott. There are different membership categories for those that are interested: national, associate, institutions, corporate, individuals. Since 2018, there is a new category that is corporate startups, and also nurses and students. Nurses and students are free of charge categories, so they can affiliate without paying fees. Students up to 35 years old and that are pursuing studies up to MSc degree. Next slide, please. Okay. So this is the website of the International Society for Telemedicine and Health, where we can find detailed information about the activities of the society, some of those that I presented here. And now we are going directly to the presentation of this webinar to be coordinated by our colleague Konstantinos Antipas about telenursing and advanced practice nursing. Konstantinos, please, you can start the session. Welcome.
Thank you very much, Adolfo. On behalf of the TeleNursing Working Group, I would also like to welcome you. Many of the people attending this webinar are members of our working group, and I'm the chair, and Claudia Bartz and Pirko Kouris, that also are attending this webinar now, are the co-chairs of the our working group. Can I control the slides myself, or?
Yes, please. Yes, please.
I don't have this option.
Yeah. Yes. All right.
Can you give me access to that? Or? Anyway, we have around 150 members, nurses from all over the world. Our vision is to extend the reach of nurses through technology and improve the quality of healthcare delivery worldwide. And our mission is to provide a forum for exchange of knowledge and experiences of nurses and others who are working with or supporting nurses using e-health applications. And that's why we organize these webinars. For you that you are a member of our working group, please use our network. Please send me emails with questions or suggestions on how to become better, or what do you need from us. Sometimes we receive questions and we're trying to, regarding, for example, practice in other countries. It's not always to give an answer, but we do our best to connect you with people, or find answers for you. And for those that are attending this webinar and are nurses and they are not members, please do it. It's, as Adolfo said, it's for free, and yeah, you get more information and also the possibility to connect with us. For today, we have the honor to have with us Rebecca Bates, Dr. Rebecca Bates, and Dr. Patricia Camillo. Both are advanced practice nurses. working in the US. And I will talk about e-health and telenursing and how it's applied in their practice. Telenursing is, okay, we all know why it's so important since we are here, but advanced practice nursing, for those that are not familiar with the term, is a role that has been, exists for more than 50 years in the US. It started there and exists also in other countries, and it's an advanced role. Nurses that are the nurse practitioners or advanced practice nurses are usually are registered nurses that have acquired expert knowledge base, as the ICN defines it, the International Council of Nurses, complex decision-making skills and clinical competencies for expanded practice. Usually these skills are acquired through a master program, and in the US, correct me if I'm wrong, Rebecca and Patricia, it has started to require a doctorate of nursing practice. So it's at the PhD level. I became familiar with this term because with this role, because in Norway we have the role has been introduced the last 4 to 8 years. It has been introduced in Norway, and even if my main research area is e-health, I've been also researching in this area, and I've been talking with some of the first advanced nursing practice nurses in Norway, and the results already in the primary healthcare have been very impressive. And of course, this replicates the positive results that have already been shown to have in the US, in UK, Australia, and many other countries. We will start first with Dr. Rebecca Bates, that is working as a family nurse practitioner at the Adams Compassionate Healthcare Network. This is a very short introduction for me. Please, Rebecca, introduce yourself and start your presentation.
Thank you, Konstantinos. So I'm Dr. Rebecca Bates. I'm a family nurse practitioner, as you said, and I would just like to clarify that in the U.S. we have had nurse practitioners for about 50 years. The advanced practice nurse practitioners or registered nurses, where you see my designation is APRN, that actually encompasses 4 different advanced practice groups. So nurse practitioners are the largest group, but we also incorporate nurse midwives, clinical nurse specialists, and certified registered nurse anesthetist. So those are the 4 advanced practice nurse roles in the United States. As a family nurse practitioner, I've been working for the Adams Compassionate Healthcare Network for the past 4 years, and I'll talk to you in a moment about my clinic in particular. But I want to let you know right off at the start that my passion is working with vulnerable populations, and I believe in the power of education, not only for our patients, but also for our students in terms of workforce development and teaching them high-quality, cost-effective, evidence-based practice. So I want to talk to you today about some things that we're doing at my clinic that I started about 3.5 years ago. So I hope that you enjoy and that you ask lots of questions, because I'm really excited about sharing this with you. So we're going to talk about the problem of healthcare in the United States. We're going to look at an interprofessional model to address the problem of underserved people in the United States. I'm going to talk to you about some novel interventions that we've implemented and talk to you about how that's rolled out and some of the barriers and challenges. And then talk about telehealth implementation in particular, and then about the experiential learning opportunities I've created for students that come through my clinic. So in case you don't know, the U.S. is the only industrialized nation who has not instituted universal health care. Given that fact, we have 5% of our Medicaid patients, which is the closest thing that we have to a government program. 5% of our Medicaid patients account for 50% of health care costs in the United States. Now, to qualify for Medicaid, you have to be low income, and that varies by state. The state can set the level for it. So I live in Virginia. I live about 45 minutes from Washington, D.C. So just to kind of give you a geographic picture of where I live in the wealthiest county in the United States. Our average annual income is almost $180,000 a year. That's huge. In our state, you have to live 138% or below the poverty line to qualify for Medicaid. That means a family of 3 cannot make more than about $9,500 to qualify for Medicaid in my state. Free clinic patients are patients who are uninsured. but they often utilize high-cost resources. Free clinic patients are patients who do not qualify for state or federal programs such as Medicaid or Medicare, which is our senior and disabled program. In Northern Virginia, immigrant communities face higher economic challenges and poorer health, mainly because they're coming from countries where they've left refugee camps, they've left war, they've left famine, and they're coming to the state to start over, and they come with very little. In Northern Virginia, in this area, we have huge population of immigrants from mainly Middle Eastern countries, mainly Muslim majority countries. So the model of care I'm going to talk to you about today directly addresses social determinants of health to optimize the healthcare outcomes, particularly for my patients. So ACHN, Adams Compassionate Healthcare Network, is a free clinic in Northern Virginia. We receive no state or federal funding. We are funded solely by donations. Just to give you an idea of what we do, we have about 850 patients that are active on our registry right now. Our total clinic budget is $160,000 per year, and that includes salary for 3 people. I'm a part-time family nurse practitioner. I work less than 20 hours a week at the clinic. I have an administrative director who works part-time, and I have a front desk person who works part-time. So the 3 of us are the only employees. All the rest of the care is provided by my advanced practice students, my registered nurse students, and volunteer providers and other volunteers from the community who are usually college students that are applying to med school. My clinic is mainly immigrants from Africa and the Middle East, Muslim predominant countries. And the reason for that is the clinic was started about 5 years ago by a few people from the local mosque. The local mosque has about 25,000 congregants and 8 satellite sites where people come to worship. So there's smaller mosque sites. My clinic is located in the front of one of those mosques. So we have 3 exam rooms, 1 dedicated office space, a front desk, and a waiting room. I manage the day-to-day clinic operations in terms of the patients, labs, imaging. I sign off all the orders and all the labs and everything for all of our volunteer clinicians. So I'm the lead clinician there. About 3.5 years ago, we started a telehealth program. My DNP, my Doctor of Nursing Practice, is from Old Dominion University, which is in Virginia, but it's about 5 hours away from here. But part of our education program is to learn about telehealth. When I moved to this clinic from private practice, I was given the opportunity to participate in a grant program that ODU had a partnership with the University of Virginia. From that, I received a telehealth cart, and I received some telehealth training and support as a preceptor. And so that launched our telehealth program at the clinic, and I'll talk to you more about the specifics of that in just a moment. Our clinic also operates with a series of specialty care providers. So things other than primary care, such as cardiology, dental, allergy and asthma, the sleep studies. So that specialty network provider base helps us care for our patients, but most of those specialty providers will only see 1 or 2 of our patients per month for free as an initial visit. But then we have to help our patients find any additional resources they need. If they need a CT scan or they need surgery or a biopsy, we help them navigate into the care that's most cost affordable for them. We also get discounts on labs and radiology, and we take an interdisciplinary approach. So we really have a great breadth of students and a great breadth of experience to care for our patients. I just want to give you an idea of where we live. This is a tri-county area, and this top part is Loudoun County, where I live. This kind of bottom middle right part that says ACHN. ACHN is my clinic. This is Fairfax County, the 2nd richest county in the United States. And this 3rd kind of lower left county is one of the poorer counties in our state. So you can see we have the richest county, the 2nd richest county, and one of the poorer counties. The areas that are darker red are the areas that have higher rates of people who are uninsured. You'll see a similar map here. We plotted out where our patients live so that we knew those barriers. So transportation is a barrier to underserved patients. Accessing healthcare services is a barrier to underserved patients. So we really wanted to look and see, where do our patients live and what services do we need to get to our patients rather than having our patients come to us. So mapping our patients has been really helpful. And just as a caveat, my husband is a PhD student who just finished, and he used a mapping program to map our patients for us. So sometimes these unusual partnerships can be very beneficial for clinics as well. This is our model of care. So ACHN is at the center, and this might look familiar to you as telehealth providers. We talk about the hub and spoke model. That's basically how this is set up as well. So you have the ACHN clinic in the center, but then we have university partners, we have community partners. Students are, I can't tell you how much they are the bedrock of the care that we provide. We are also a member of the State Free Clinic Association, which gives us some support in terms of board guidelines for our board of directors. It gives us free flu shots in the fall. They have a conference once a year, so the 40 free clinics in the state of Virginia get together and we kind of talk about our barriers and challenges and successes and resources and help each other out in terms of just ideas and brainstorming. We also have some partnerships with healthcare systems. So one of our largest hospital systems here, we have a good relationship with them and often use their charity care program to help with getting our patients into care. The problem with our patients is many of them are not U.S. citizens. They may be green card holders, they may be recent immigrants or asylum seekers, and so they have various levels of immigration status. And so because of that, they don't qualify for most of the state and federal programs that U.S. residents would or U.S. citizens would. We also partner with social services, so we have free food programs, we have food bank programs, we have school health programs. So we look at a lot of those social service programs. We also partner with like job training programs and other things like housing help or people who are going through legal trouble because they've lost their green card or something like that. And then of course we partner with our patients on a daily basis in an intense high-touch way. You notice the title of this program is Hotspots, and I'll tell you why that's important. So we need to define those high-risk patients. Those high-risk patients are those patients that have increased risk for disability, death, so morbidity and mortality. The reason we want to target high-risk patients is because that's where we're going to get the biggest return on investment. The patient comes in with already controlled diabetes. We don't have a whole lot of work to do. We have a lot of maintenance, right? But a lot of our patients come in having never had health care, or the health care they've had has been very sporadic. They'll walk into the local pharmacy, tell somebody I have high blood pressure, they'll get pills for high blood pressure. They don't understand the self-management part of it. And so their blood pressure has been uncontrolled for years. So those are our high-risk patients. One of the ways that we identify who those are is we've created a patient care registry. And so this is an ongoing living document that we keep updating quarterly that evaluates our patients that have diabetes, hypertension, hyperlipidemia, and obesity. And so at a glance, I can look through and see which patients have uncontrolled diabetes or uncontrolled hypertension, which ones we need to target with our telehealth initiatives in particular. We are able to, in this clinic, create and test interventions to improve outcomes for these high-risk patients. We do that through our doctoral students who have to do a year-long project. And so they will come in and they'll spend a year with me and with our patients, and they'll develop some sort of project. So we've had medication reconciliation projects. We've had telehealth use for diabetes self-management, but also shared medical appointments for diabetes delivered via telehealth. So they've been able to test and create and test some of these different interventions that specifically target our higher risk patients. We have myriad partners who volunteer with our clinic, including physical therapy, registered dietitian, pharmacists, ophthalmologists, cardiology, dermatology. Pain management actually comes to the clinic once a month and does acupuncture or joint injections as needed. We also have optometry. We have an optometry clinic that had been running once a month until our optometrist decided to go back to medical school to be an ophthalmologist. So we're hoping he will come back and volunteer once he finishes his schooling. I have a former student who owns a home health agency, so when we have patients discharged from the hospital that need home health, I can call on her and she will mobilize her team and provide home health services for free. And then we have a bunch of primary care physicians that come in and staff the clinic when they want to. So we have a dedicated GI internal medicine physician who comes on Mondays. We have an internal medicine physician that comes on Wednesdays. And then we have an internal medicine physician and a physician's assistant that come on Saturdays when I'm not in the clinic. We also find different ways that we can engage patients in treatment. So whether that's via telephone or more likely through telehealth, through frequent contact with our patients, through our students calling them back with their labs or our staff calling them back with their labs and asking if they have any questions, checking in to make sure that they keep up with their medications and that they're getting their medications filled. That high-touch care really makes a difference in patient outcomes. In our clinic, we have had students who are family nurse practitioner students, adult gerontology nurse practitioner students, social work students, psych mental health nurse practitioners, of course D&P students, public health students. We've also had community health students, and most recently I've taken on groups of registered nurse students to teach them about community health. The U.S. really focuses on RNs in the hospital setting, in the acute care setting. And I know that nurses in other parts of the world have more autonomy and spend much of their time in the community setting. And so I try to create an environment where our RN students can imagine life outside the hospital and really utilize all of our nursing skills to help keep our population healthy and really work on that primary and secondary prevention. As I've already been talking about, we provide high-touch care and we provide a lot of care navigation, and that means navigating people into the care that they need, whether it's getting them into charity care at the hospital, getting them into a specialty care, getting them a service, such as I have a patient that we just were able to get cochlear implants for him with hearing loss. So that care navigation is really important. The hotspotting came out of, the term hotspotting came out of an article that was in the New York Magazine that was written by Atul Gawande. If you don't know him, he's a physician surgeon who is also a journalist and author and frequently writes for the New Yorker. So a number of years ago, he wrote an article about hotspotting, and it highlighted an initiative in Camden, New Jersey called the Camden Coalition Model that really started focusing on those high-risk patients, the patients that came into the ER frequently, often spent weeks in the ICU because of uncontrolled, unmanaged chronic diseases. And I thought, we can pull that back to the primary care setting and target our patients before they end up in the ER, before they end up in the intensive care unit. So that is always our goal, keep our patients out of the acute care setting and do as much as we can to provide self-management education and high-touch care to keep them healthy and well and help them to understand the disease process, help them to understand how they can be healthy and well. So I've already talked to you about the patient care registry. I've talked to you about the high cost of healthcare in the U.S., and people often access the emergency room for things like sinus infections, a simple cough, a simple cut, an ear infection, those types of things that should be managed in primary care, but because they're uninsured, the ER becomes their only option. Our goal is to build relationships with patients and families, and so with the population that we serve, we will often have people who are in their 70s or 80s, and then their children who are in their 50s or 60s, and then their children who are in their 20s or 30s. And so it really is nice to be able to truly practice family practice. One of our challenges, however, is that I don't speak most of their languages. So on a daily basis, we'll hear Amharic and Urdu and Arabic and many, many other languages from Northern Africa and the Middle East in particular. And so we really struggle with translation services. In the U.S., a translation service costs about $1.25 per minute, and our clinic just cannot afford that. So we often use telehealth to bring in a translator, or the patient will ask for one of their family members to translate for them. So we try to get creative in the way that we are able to offer translation. We also have, my administrative director is a physician who is trained in Pakistan, so he speaks Urdu, so when he's in the clinic he can translate for us. He's not licensed as a physician in the U.S., but he is our administrative director. And then my front desk person is a physician from Ethiopia, so she speaks Amharic. So when I can pull her away from the front desk, she can translate Amharic for me. But other than that, we have to rely on our students, the families, and also volunteers who will come in via telehealth to provide translation. Because we have patients from so many different countries, we also have to work on culturally appropriate health care. So when we're talking to somebody about diabetes and food choices and food modifications, we use a lot of resources that are based in their culture. So we have had our specialists from different countries offer suggestions for modifying those. So we really try to provide the healthcare that people will understand and appreciate and be able to live with. Because if I tell you don't eat at McDonald's, they're not eating at McDonald's anyway. But if I tell them, that we need to cut down on that rice that you're eating or cut down on the fufu, those types of things are much more helpful. And then what kinds of vegetables do you eat? It's probably different than what I eat. So we try to make that more appropriate for them. I've talked to you about care navigation already. And then the most important thing that we do is telehealth as a tool for patient engagement. So one of the things that I started about 2 years ago was creating student dyads. Student dyads just means 2 students. They're advanced practice students or a social work student and advanced practice student or an RN student and advanced practice student that will go into the patient's home, take some telehealth equipment with them, and by that I mean a creative array of a laptop, a hotspot device that will connect to the Wi-Fi, and then peripherals, so a dermoscope, an otoscope, and an electronic stethoscope. Through that, the students will go to the patient's home. They will visit with the patient. They will basically do a home health visit. They'll take their vital signs, their history and physical, and then do some self-management education. And then they will connect with me while I'm still in the clinic, and I will visit with the patient via telehealth. The students will present the patient to me, tell me what's going on with them, and I will be able to talk directly with the patient as well and find out, how they're doing, if there's any modifications to their treatment plan that we need to do, if they need updated medications, if they're due for labs. I can order all of that via telehealth, via that telehealth connection. So that's one of the ways that we're using telehealth, and I think that's the most exciting way. Now, what you should know is that in the U.S., that direct-to-patient care is not reimbursable. So if I were in a private practice, I would not be able to do this in most settings. Some of the rules are starting to change now for our Medicare patients. Those are our elderly and disabled. But across the board, in general, direct-to-patient, direct-to-consumer care reimbursed by insurance is just not quite there yet. So this is really a unique offering that even our private clinic patients wouldn't be able to get. So I have 3 grants. I told you already about the APN place, which is how I got the telehealth card. That's the second one on this list here. The first one on this list is Telehealth Technology-Enabled Patient Care Teams. I've told you a little bit about what advanced practice nurses do in the U.S., the 4 different roles. In the U.S., each state is able to regulate the practice of nursing at all levels differently. So I used to practice in a state called Rhode Island, where I had full practice authority. I didn't have to have a physician oversight. When I moved to Virginia, I had to have a physician collaborator. And I could not practice unless I had on paper a name of a physician who told me exactly what I could do, what medications I could prescribe, what procedures I could do, and what types of patients I could care for. About 5 years, maybe 7 years ago, that got rolled back, and now we have to have just a piece of paper saying that this is our collaborating physician, and that if we have a patient that is complex, we will collaborate with that physician. Just this year, we now have the ability to practice independently of a physician, meaning I can open my own business if I want. I can practice without a collaborating agreement. But that's only for nurse practitioners that have 5 years or more, 9,000 hours or more of practice. So 2 years ago, before we had this independent practice, we had a state telehealth pilot program start that was supposed to help those of us who still needed collaborating physicians to connect with a collaborating physician. Out of that, we got a telehealth platform and training on telehealth. And so I figured this was a great way to get my patients connected. So this affords me a telehealth platform that I can use to connect with my patients on a regular basis. So if I have a patient, for example, that we're managing diabetes, they don't need a home visit. They just need somebody to check in with them maybe every 2 weeks so we can review their blood sugars, so we can review their dietary intake, so we can review whether or not they're adherent to their treatment plan in terms of medications and exercise. That visual connection through a telehealth platform so I can see the patient and they can see me is so amazing. The patients love it, especially when we have to have a translator. We can bring that translator in for that connection also. So that's another creative way that we're using telehealth. And the last one I want to tell you about is something I will be starting in about a month, and it's called DI. It's a way to look at, to evaluate our patients with diabetes and hypertension for retinopathy. So it's a little device that attaches to an iPhone where you can do an in-office exam to examine the eye for disease. You can take still photos, you can take video that can go to a secure platform that can be read by an optometrist or ophthalmologist for confirmation if needed. Also, if I'm referring somebody for ophthalmology consult, I can send along this photo or this video so that they can see what I saw and reevaluate using their specialized equipment. The cool thing about DI is you don't need to dilate the eyes to be able to use it. So this will likely be one of my DNP students' projects going forward starting in the fall, but for right now we're getting this program up and running. because one of the things we have trouble with is getting our patients who need these routine screenings such as pap smears and eye exams and colonoscopies. We have trouble getting people into that care because those tend to be higher cost evaluations. So being able to offer this to our patients, some of whom have never had an eye exam, can be really helpful in risk stratifying those who need additional care or specialty care. So I've highlighted here, this is a list of telemedicine programs and challenges. And I highlighted here some of the things that we've had trouble with. So the barriers have been lack of a common EHR. So right now we're using a free version of a platform called Athena as our electronic health record. Most of the other practices in the hospital systems do not use that platform, and right now they don't talk to each other. Lack of integration with the current EHR, my telehealth equipment does not connect to my EHR. So if I want to take a still or a video, I have to download that as a file and then upload it to the telehealth platform as like a document. There are no native capabilities of the EHR, so telehealth is not built into there. And then I don't have specialist physician coverage for telehealth in general, except for ophthalmology, where I have an ophthalmologist that's willing to help read some of those DI exams. I don't have physician coverage via telehealth for any of the specialty care yet. I'm still working on it, but we don't have that yet. So that's why we're using telehealth in different creative ways to maximize the role of the nurse and maximize the role of the advanced practice nurse. And then we're always struggling with spoke partner recruiting. So that means that some of the specialty care, some of the care outside the clinic. So we have partnerships with multiple universities. I graduated from ODU with my DNP, so they're one of my partners. I've precepted students from UVA and have that joint grant between ODU and UVA, so they're one of my partners, and I do have their students in my clinic. I was on faculty at George Mason, GMU, George Mason University for a while, and I'm now a PhD student there. I've also worked with George Washington University, and I precept their students. Shenandoah University is another local university, and then many others. So we have a lot of distance learning programs in the U.S. right now. So a lot of our students that live and work in Virginia, but they're going to a program, say, in St. Louis or in Colorado that's a distance learning where they only have to be on campus once or twice a semester. I've already told you about the breadth of students that we have, from community health and RNs to FNPs, and then lots of volunteers at the clinic. And our volunteers are interested in the telehealth, and for some of our volunteers, they've never seen telehealth in use before. So about 3 years ago, which is the latest statistic I have, only about 20% of providers in the state of Virginia were actually using telehealth. And so I believe it has increased since then, partly because of the state telehealth pilot program, but partly just because people are learning more and more about what telehealth can do and potential applications for it. So our physician colleagues and other people that rotate through the clinic are really curious about telehealth, so I'm able to also expose them to different ways to use it and potentials for connecting with our patients that way. I've told you about our network of specialty care, and then the community engagement piece is really important. We go out into the community and we do health fairs, we work with other people in the community, and telehealth can be a way that we can continue to connect with our partners in the community, so we can have meetings with other free clinics and other providers via telehealth as well. So it's not just for patient care. The other thing that we can do is we can connect with, when I have students in the clinic, I have to connect with their faculty regularly. So as their preceptor, I have to give reports back to faculty. Instead of the faculty having to make a drive out to the clinic, they can observe the student interacting with a patient via telehealth. So what another cool way to be able to use telehealth applications. So our advanced practice students, our social work students, and our psych mental health students are all educated and trained to do SBIRT screening and SDH screening. SBIRT is screening, brief intervention, and referral to treatment, and it's a way to screen patients for tobacco, drug, and alcohol use, and then provide a brief intervention if they are using tobacco or drugs or excessive amounts of alcohol, and then if they need, referral into more treatment. So all of our students are trained in SBIRT. And then social determinants of health screening, because you cannot be healthy if you don't have safe and affordable housing, if you don't have food on your table, you can't possibly manage your diabetes or hypertension unless you have those things in place. We screen for those things. We ask people if they're in an abusive relationship. We ask if they have a safe place to live, if they have food on the table, if they're able to get to the clinic, if they have transportation issues. So we ask about a lot of those social determinants of health. We also, like I told you, we do a lot of DNP projects, and the DNP students are really creative in what they come up with in terms of their different models of care they want to test at the clinic. And a lot of them have involved telehealth because they're very interested in bringing telehealth into their own practice and being able to go to a potential employer and say, I know how to do telehealth. I can help you get a program started because I have experience with this. And then we use, like I said, our public health and our community health students have started our registry that we're keeping updated. And as more students come in, they will also help to keep our registry updated. So as a solo practitioner, it's very hard to kind of keep on top of all these different programs. So the students are really beneficial. It's good for them in terms of workforce development, but it's eminently helpful for our patients to receive the benefit of their student status, but also of their creative and energetic status. We practice interprofessional education and interprofessional practice. So of course, all these students together, even though we might have 6 or 8 students in the clinic at a time, they'll often work with a patient two on one, so 2 students in with 1 patient, because they get different perspectives. They learn from each other and they learn from the patient. They also come in, we have a very multicultural area up here, and so a lot of our students do speak other languages and are from other countries. And so they are really able to help educate the rest of us who are not from countries other than the U.S. in terms of culture and in terms of food choices. And so they have really helped to improve our cultural sensitivity and our cultural education at the clinic. And then they all get to use telehealth. They all learn how to use it. They all think about different applications. They either go out to the patient's home, or they use it for translation, or they use it to connect with the patients. So we really value our student education portion. Our patient outcomes, partly because of telehealth, means that our chronic disease management is really excellent. Somebody might come in with an A1C of, say, 13 or 14 through metformin and very, very targeted self-management education, high touch, meaning following up with them every 2 weeks or so. Through that high touch hotspotting, we are able to drive those A1Cs down, usually to 8 or 9, with a little bit of metformin, a lot of self-management education, and frequent contact. That's the power of education. We really encourage our patients to set SMART goals, and we help them set SMART goals, and I'll show you in the next slide what that means. And all of them receive self-management education every time they come in. So typically our office visits are 30 to 60 minutes for most patients, especially for the first or second visit. And then after that, the visits might be 20 to 30 minutes. But we really focus on that self-management education. We always ask about their food choices, about their dietary habits, about their exercise habits, about their sleep habits, about their medication adherence. All of those are important to remind them, give them gentle reminders that, exercise is just as important as your medication, for example. So because of these initiatives, we've had improved diabetes control, decreased BMI, decreased blood pressure, improved medication adherence, improved SMART goal attainment, and some of our patients have actually moved on and become eligible for insurance, and they are now insured. And some of them will come back and say, I love seeing you. Can we continue seeing you? And we have to say, I'm sorry, we're a free clinic. We don't take insurance. So they have to be out in the community. So patients really value the care and the time and attention that we have devoted to them as well. So if you're not familiar with SMART goals, this is what they are. S stands for specific, so exactly what do you want to accomplish. Measurable, so it has to be something like bringing your A1C down or exercising 3 days a week for 20 minutes each if you're just getting started exercising. And what will that be? It will be walking around the block 3 times. Achievable, is it something that you can do? If I tell my patient who's never exercised in their life to go out and run 2 miles, they're not going to do it. But if I say, can you go out for a 5-minute walk every day after dinner? They can say, yeah, I can do that. So that's an achievable goal for them. And the next time they come back, maybe we'll up that to 10 minutes, or maybe we'll ask them to walk a little faster. So those are the achievable goals. Relevant, is it important to them? Is it something they want to engage in? Is it something they value? And is it something that's going to be beneficial for their disease outcomes, such as blood pressure management or diabetes management? And then time bound. So over the next month, I would like you to work on exercising every day for 10 minutes, right? Give them that period of time in which they have to accomplish that goal. When we set those SMART goals, patients are more likely to meet them. When we're vague and we say, go out and exercise, or don't eat that, or decrease your carbohydrates, those vague goals are not helpful for our patients. And so setting SMART goals is something, and revisiting those SMART goals is something that we can do very easily through telehealth. So when we have that telehealth connection with our patients, we'll say, okay, how are you doing on your walking? Tell me about your activity level lately. And then once they've met that goal, then we help them set a new goal that is based on whatever their treatment plan is, such as getting their A1C down to below 7, for example. And the patients really have something to work for then. They write those goals down, and then we talk about them a week or two later whenever we connect again. So our clinic outcomes, I've told you we have high-quality evidence-based healthcare. We have cost-effective interventions in that our telehealth programs, all of the telehealth equipment we have has been provided via various grants. So I have not had to pay for any of the telehealth equipment, which is pretty awesome. But that also means that if something breaks or I lose connection for some reason, that I have to figure out how to fix it. We're always looking for new community partnerships, and specifically for specialty services that can connect with our patients via telehealth or that we could use for e-consults, because that would be really beneficial for things like different hematology disorders, for example. And then reaching out to the community and providing a bigger community impact. One of the new initiatives that we'd like to start with telehealth is to move out into like low income housing areas or additional underserved areas using, again, kind of a dyad model where 2 students would go out and evaluate the patients and then connect with me via telehealth. So that would increase our capacity for being able to reach patients who can't physically get to us for a variety of reasons. So just to give you an idea of the work that we're doing at the clinic, I told you our yearly budget is about $160,000. The clinic started in 2013. In 2013 and 2014, the clinic was only open on Saturdays for 3 hours. So those first 2 years, they were only open 3 hours once a week. I started in July of 2015, and I started working, I'm at the clinic 17 hours a week. So since 2013, since inception, we've provided over $1.5 million of services provided and cost savings to the patients. And you can see the majority of that was through office visits. So a typical office visit here in the U.S. would cost $75 to $100 if they had to pay out of pocket. So just that cost savings alone is huge. But we have a partnership with a local pharmacy that has 14 other free clinics that are part of it. And so they buy prescriptions in bulk, and the patients can get those for $5 for a 3-month supply. Now, the formulary is kind of limited, but we get the majority of the medications that we need through them. 12% of our cost savings has come through referrals to our partner specialty providers. And then our volunteers, which include our students, have provided a number of specialty services as well as just high-touch care with our patients. We have, I just saw a question, how long are our students in the clinic? Some of them are with me only 1 semester, which is about 15 weeks. And some of them, the DNP students, tend to be with me for 3 to 4 semesters, depending on the length of their clinical program. Our RN students are from one of the local universities, and their community health requirement is that they spend about 50 hours in a community health setting. So they're with me usually for about 6 weeks. And so we have the first half of the semester I have 2 RN students, and the second half of the semester I'll have 2 different RN students. But they do a lot of the care navigation. They use telehealth for connecting with the patients to talk about labs and that kind of thing too. So the next steps is I want to reevaluate the current program and specifically the telehealth program to find out the impact of just the telehealth piece. One of my barriers to doing that is although I'm a PhD student and I have a DNP and I teach as an adjunct faculty for ODU, I am not able to submit anything to the IRB because the universities require that you are a full-time faculty member to be able to submit to the IRB. And the faculty at those universities don't have an affiliation directly with the clinic. So I'm trying to get them to agree to be a volunteer at the clinic so they can submit to the local IRB so we can start getting some of the results that we have published. Because I think that the power of what we do is really important to disseminate to our wider community. So I really appreciate this opportunity to share some of what I'm able to share with you right now today. I do want to have all of our providers trained in telehealth. All of the volunteer providers and all of the students and volunteers that run through the clinic should know how to use telehealth. If you think about it, we use it every day to connect with family and friends. And the telehealth that we use with our patients is really no different. It's a video teleconferencing platform that is HIPAA compliant. And actually, the platform that we use has Zoom built in to the video teleconferencing. And a lot of us use Zoom. It's super easy to use. You click a button, it pops up on your screen. You can use a smartphone, a tablet, or a computer. So I would really like everybody to be trained in telehealth. And I think those types of things will help with the increased utilization of telehealth to connect with patients and to connect patients to the care they need. Because I think that's one of the biggest barriers is when patients have to take hours off of work to drive to an appointment, sit and wait in the waiting room, when if you can connect via telehealth, you log on at the appointed time and you log off when that appointment's done. So it minimizes that time impact, which means for my patients in particular, time off work. Time when another family member has to drive them to the clinic because they have severe cataracts and they can't see, or they don't have a license in the U.S., right? So this helps our patients connect to care better. Starting that DI initiative to be able to do the ophthalmology exams is going to be huge. Our patients will be able to be screened and get into the care that they need faster rather than waiting for an appointment a month or two down the line. Increasing the use of telehealth, so like I said before, I really want to create more community partnerships and be able to utilize the equipment we have and the ability that we have to provide healthcare services to the wider community as needed. And then sustained funding. So eventually this equipment that we have is going to wear out. We'll need to continue getting new grants. As a free clinic, it's really hard to do because we don't have, we're not part of a university system. We have affiliations with them, but we're not part of a university system. So some of that sustained funding just comes from private donations from our community members. So that's all I have to share with you today. I really appreciate the time and your attention, and I'm happy to answer any questions whenever we have that opportunity at the end. So thank you very much.
Thank you, Rebecca. Thank you. It was very interesting. We will have a discussion. Presentation. I would like to invite you to write some questions for those that they are still with us, and you can write them. There's there was one question regarding the notes. I know the session will be recorded, and then you can watch it later. But regarding the PowerPoint presentation or the PDF, I will have to discuss with the presenters if it's okay for them to share the presentation. So we will, yeah, we will do it after by email later. Any questions? Until someone, I think might have, yeah. Until we get some questions from others, I would like to ask Rebecca this. Yeah, there are some things that first of all are a bit different, and I didn't understand because of the very few things I didn't understand, but it has to do with the different the context that's different. And then you mentioned that physician coverage doesn't cover the telemedical telehealth part. Can you explain this a bit? Is it
Sure.
different?
Yeah, so telemedicine is a way that, so when we need a physician collaborator, or when I need to connect my patients to specialty care and I would like to do that via telehealth, for a physician collaborator, a physician can be located anywhere in Virginia. As long as they're licensed in Virginia, they can become a collaborator with a nurse practitioner if they agree to it. The flip side of that is that physician can charge whatever they want. So they can charge $12,000 a year, $20,000 a year, whatever, and they may only review one chart a month. So even utilizing telehealth to have a collaborator isn't really a great option for a lot of people. I don't want to be disingenuous. About probably 70% from our latest survey of the state in the state of Virginia, about 70% or so of our physicians collaborate with our collaborators for nurse practitioners because they work in the same practice. So when I was in private practice, one of the physicians was my collaborator. I didn't have to pay them. They were just assigned as my collaborator. When I started at the pre-clinic before I was independent practice, the medical director of the clinic was my collaborator. I didn't have to pay him. I was hired and he was assigned as my collaborator. So that's one thing. When you have a specialty provider that you want to send your patients to, usually those specialty providers expect to be paid through insurance reimbursement or expect to be paid with cash. My patients are uninsured. They pay nothing to come see me, and their labs and their radiology and that kind of thing are heavily discounted. They do not have the money to spend $150 or $200 for a physician consultation where they may only spend 5 or 10 minutes with that physician. So what I struggle with is trying to get specialty providers that are willing to at least do an e-consult or see the patient for free once just to confirm my findings or to help with a treatment plan. For example, I have a patient with rheumatoid arthritis that takes methotrexate, and so I am able to get a treatment plan from a rheumatologist, and then I can continue that patient on the methotrexate with regular labs and regular evaluation and management, and then they only have to see the rheumatologist once a year. So that means they're only paying $150 to $200 once a year rather than every 3 months, as is typically required. So the specialty provider consults are really what I have trouble connecting my patients to care for via telehealth. That being said, we have a handful of providers that do volunteer their time and services, such as cardiology, such as dermatology, and so if I can get them to work with me on telehealth, I could do a dermatology consult very easily. I have a beautiful derm that takes wonderful pictures, so I could do skin evaluations, I can look at lesions, I can capture that as a still picture image in high quality picture and send that to the dermatologist if he would agree to participate in telehealth, but he hasn't done that yet. So I'm still working on those specialty providers. Does that answer your question?
Yes, thank you. Do you hear me now? Thank you for this. I have a question for Pat, but I guess also Rebecca can answer afterwards. How common is this telenursing or telehealth use for nurse practitioners in the US? And then for Pat, she also mentioned this that there are some organizations that try to make this very like put time limitation and make it very effective. Again, what is the balance, or how often nurse practitioners work for this organization, and how often they take the initiative to do it on their own?
From my experience, nurses are very reticent and they're not true. They're not really entrepreneurial in spirit. They like to be part of an organization, and that's fine. The problem is that our voices in whether this is hospitals or larger organizations that are just for telehealth, our voices are not often heard, and we are nursing's voices are not always heard. And so many times our practices are being defined by other people with different motives and agendas. A lot of the telehealth companies out there right now are rigorously recruiting nurse practitioners to be providers but their agenda and their motive is, and because some of them are even public companies, is to make money for their shareholders, and so scale is a very important issue for them. And so, we have very different motives and agendas, and I really worry that that our practice, that has been altered by others in the past with similar situations, is going to be affected, and that I think we need to get ahead of this. I think we need to get ahead of it by joining startups. I chose Doxy as my video platform because it's a startup and it's simple, but I also then have my foot in the door to a startup that is, so I can help shape the way this kind of thing is working, rather than just become an employee later on of a large corporation that is going to tell me that I need to use these algorithms and see this number of patients on this amount of time. So in the U.S., it's not common for nurse practitioners to choose an independent route, but I'm sort of on a mission to help encourage that a little bit more so that we can keep the integrity of what is nursing science and the art of nursing in telehealth. Yeah.
And I'll jump in and give my 2 cents too. There's been a lot of research about how people practice, especially in interprofessional education. And if people are not taught that during school, during their education, they're not likely to adopt it after they graduate. So part of my education, my doctoral program, was telehealth. ODU has a really great handle on teaching telehealth to advanced practice nursing students, particularly at the doctoral level. And so that's where I learned it. And then when I came out into the community to practice, I was able to bring that with me. And so part of my mission, like Pat, is to really, be a champion for telehealth and for telehealth nursing, because the skills and the knowledge, the skills, and the abilities that we have as nurses, the experiences that we have with partnering with patients at all levels of care and from all different types of communities and settings really lends our skill set really, really well to being able to partner through this synchronous environment in a virtual telehealth consult.
Hello. Hello, it's Adolfo from Brazil again. Good afternoon, good morning once again. I have my own question, but I see that on attendee chat, there are some comments and questions from the audience. For example, Maria del Carmen Taquia asks, I think to both speakers, the question, do you know any nurse teaching program to introduce them to the telehealth system at the hospitals? This is a question.
So this is Rebecca. I'm part of the Mid-Atlantic Telehealth Regional Consortium, which is, I live in one of the Mid-Atlantic states. So this extends up to like Pennsylvania and Rhode Island and down to Virginia and North Carolina. So this whole section is the Mid-Atlantic region. Up in Pennsylvania, there is a university health system, Jefferson Hospital System, and they have a program called Jeff Connect, where they really get their students in a program to learn about telehealth. They get a certification at the end. So that's one option. In Virginia, we have a program called Star Telehealth, where anybody can sign up to learn telehealth and then also get some hands-on learning with touching the equipment, utilizing the equipment, especially peripherals. So being able to do remote patient monitoring, using things like the dermoscope and the electronic stethoscope, and at the end you get a certification. Old Dominion University is starting a telehealth program where people can go to the center and actually utilize and try out various types of equipment, as well as become an education hub for telehealth in the state as well. The Star Telehealth is based in kind of the southern part of Virginia, whereas ODU is in the northeastern part. So there are some university programs that are offering telehealth. Interestingly enough, there's another very large university care system in the state that is like the center for telehealth for the entire state, but they do not teach their nursing students or their medical students to use telehealth unless those students actively seek out telehealth experiences. So I think that translation of what's being done in the capabilities and the possibilities really need to be better incorporated into the education system at all levels of nursing education, but also all levels of healthcare. I mean, I know an orthopedist that is using telehealth to do follow-ups for his student athletes who travel from out of state to go see him. I know of a physical therapist that does some physical therapy consults via telehealth. So it should not be limited to just only talking. It can also be a lot of good follow-up care for some specialty care providers as well. So I think it's beneficial to consider how it can best be incorporated into a curriculum.
I think there's more, and this is Pat, I think there's probably in terms of training, there's a lot more emphasis placed on those peripherals, and they're very useful. I mean, from a hospital perspective, if you can be monitoring somebody with congestive heart failure at home and limiting their use of being inpatients, that's great. And so I think there's a lot more emphasis in the hospital systems to really help nurses work with those kinds of peripherals. Where I'm seeing the real holes is how do you actually engage and create that connectedness over that computer screen with a patient. So aside from, the fact that technology allows us to monitor and to measure and do all those really important things, okay? But it's also critically important to create that connection and that personal intimacy to be able to have that therapeutic effect for positive outcomes with patients. And I think that's what's missing in the education across the board. And I have not seen that be the focus. And I have not seen nursing describe itself and its practice in this arena well enough. It's certainly not in the U.S. that I'm aware of.
Pat, I appreciate that comment about connecting with the patients, and I love your idea of having the woman write a story about herself so that you can create that connection. For me, I see all my patients in the clinic first before we offer a telehealth visit. So we already have that in-person connection. And the telehealth visits do not replace regular in-person office visits where I can do a monofilament and listen to their heart or do their neurological exam. But they do augment it, and they do allow me another way to connect. It's just a tool for connection. In my practice, it doesn't replace it.
Yeah, I would agree. I think, as I mentioned in the presentation, a blended approach like that is, especially in complicated, primary care practices, is really a better way to go, so that you can have all opportunities to make that connection. But there are practices and there are corporations out there that are wanting this to be 100%. And, I have real concerns about that. I think, there are real concerns.
I absolutely agree with you on that.
Okay. There are some other comments through the chat box. I see that our colleague and Vice President of the International Society for Telemedicine and Health, Pir Kukuri, says that she totally agree that nursing is good also in virtual environment. And during 3 decades, I have to regularly answer, is virtuality destroying interaction? So she says, in my opinion, it's not. This is just a comment, she said. And we have also some comments from Eric Kwabia, congratulating the speakers. Also from Sriani from Padmalata. She says that thank you both for your great presentation. It's really interesting and I was amazing, but I'm a little bit curious about application for nursing care. As you said, Rebecca, touching is the most important part in nursing. If without touch, how is the population perspective acceptance in telenursing application? And there is another comment from, Robert, congratulate for the very successful webinar. And Claudia Bartz also has a question. Both presentations are very good, very interesting. What is the clinics run by ANPS? Is it a sustainable model?
Should we start answering that? Sure. So I'll go back to Suriana first. So high touch care does not actually mean touching the patient. It means high frequency of connection with the patient. That term high touch can mean an in-person visit, but it can also mean that frequent follow-up with patients. So it is an important part, and that's why we see our patients in the clinic at least every 6 months, while we may follow up with virtual visits in between for those higher risk patients, or for people who just can't make an appointment and we just need to see their blood sugars or their blood pressures or something, or we'll do home visits for them. So we're trying to make a good blend. As Patricia said, that blended model is really one of the most effective. And then the other question was about using the future for free clinics run by advanced practice nurses. It is a sustainable model. In the U.S., there are tons of federal grants in particular for workforce development for nursing. Medical education in the U.S. is subsidized by the federal government. So when our physician colleagues go to their residency programs, the residency programs are paid through funds from the federal government. And that's just a given. For nursing and for advanced practice nursing, we have to decide that we're going to work in a rural or medically underserved area. And a medically underserved area is a federal designation. So my clinic, because it's 45 minutes out of DC in a relatively well-to-do environment, it is not considered a medically underserved area. So even if I applied for one of those programs to have loan forgiveness, I would not qualify for it. But I have worked with, this is the fifth free clinic I've worked for. The last free clinic I worked for before this was part of a university system that has a series of clinics throughout Northern Virginia in school settings, in community services boards, just in small locations in the most needy areas. And those are all run by advanced practice nurses. And so those models are very sustainable in terms of getting the federal dollars for workforce development for those nurses, for those advanced practice nursing students, as well as for undergrad nursing students and other health professions. But when you have an advanced practice nurse who is skilled and experienced in primary care running a free clinic, absolutely, we are cost effective. We have high quality care, and we have a lot of evidence supporting our care. There was some latest research that shows that nurse practitioners in states that have granted full practice authority, advanced practice nurses are more likely than our physician colleagues to work in rural and underserved areas. And that research was by Peter Burhouse out of the University of Minnesota, who's a health economist and a nurse. There's also been some research that, many decades of research, that demonstrates that our outcomes for patient care are as good as or better than our physician colleagues. And part of that, I would argue, is that all of us are nurses first before we become advanced practice nurses, meaning we all have experience as a registered nurse before we move into this advanced practice medical provider role. And so we bring our nursing skills and our ability to connect with patients and all those experiences with us as we move into into different settings and different environments. So yes, I think that it is a sustainable model. It is absolutely a great model for free clinics. I would say the majority of free clinics in the state of Virginia and in Rhode Island where I've worked and in New York State where I've worked and in Maryland where I've worked, the majority of those free clinics are run by nurse practitioners.
Can I ask something related to that? Does it, in a way, add to this the telehealth component, making even more sustainable or effective?
Does telehealth make it more sustainable and effective? Is that your question?
Yes, that's what I'm asking.
Yes, I think it does. You know, when we have already created a relationship with our patients and we're offering them a different way to be able to connect with us, I think it does create a more holistic environment for our patient. So for example, in my EHR, if I sign off labs and I send the patient a note saying, hey, your labs are great, good job, right? That's giving them a little bit of praise. But if I connect with them via telehealth, and I can say, you did a wonderful job. They can see the smile on my face. I can ask them how they're doing. I can see their environment. I can see in their background. I can ask them, you know, show me what you're eating for lunch today. And they can hold up their plate and I can see it. Those connections are really powerful. And yes, I think that as more and more advanced practice nurses are being exposed to telehealth and learning that it's not the scary something new, it's not a new role, it's just a new tool. Think about, you know, 150 years ago when the stethoscope was introduced. Who wanted to use that, right? But we all learned how to use it, and now it's just a part of our life. I think telehealth will get there, but I think it's also people who are those early adopters or those champions for telehealth and creating new models of care and creating new opportunities for students to learn and patients to learn and patients to become familiar with this tool. You know, it really is just that we're connecting with our children and our family and our friends across the world. It's just another way to connect with our healthcare providers and for healthcare providers to connect with their patients. So yes, I think it is going to be taken up much more widely, especially as we have more and more studies showing its efficacy and that it drives down costs and improves access to care, especially for these vulnerable populations.
So Rebecca, I have a question. What do you use for your video platform?
It's called Adaptive Telehealth. It also is a mental health-based platform, so it's not really good for primary care, but it has Zoom embedded in it, and it was offered to me by the state telehealth pilot program. Okay. And so I don't have to pay for it.
Right.
The other platform I have is a telehealth cart that is a Cisco cart, and that has the peripherals on it. So I figured out how to get the peripherals to connect to a MacBook so that I can use the MacBook to open up the Adaptive Telehealth to use telehealth peripherals through that platform. So I've had to be really creative and get a little IT help there, but yeah, so I use Adaptive Telehealth. But I also run a federal program at another free clinic where we do use DoxyMe, and it's beautiful, and it's so great, and that's a mental health-based program, and so our psychotherapists use DoxyMe all the time for connecting with patients, so it's really a great tool.
And you know, what I'd like to say for everyone who's listening and a lot of internationals who might be interested, the very simple version of some of these platforms can be available free. So DoxyMe is actually the simple version of it is available for free. Right. And you know, so there's almost no excuse for not at least adding that piece to one's practice. Yeah.
All right. Dear Konstantinos, I think we have just more 5 minutes for finalizing the session. So if you have some comments, and I would like just to leave some messages at the end of the session. So please.
Thank you very much for the both Rebecca and Pat for their very interesting presentations. It was very interesting to see how even if it's different context that I am used and maybe some of other from the audience are used to, it's very interesting to see how telehealth and telenursing is applied in the US. And also like it was very a nice introduction from Rebecca and practical and also outcomes and how this connects very well with education, which is also very interesting aspect in advanced nursing practice and telenursing. And then Patricia's presentation was also very interesting, had also a theoretical and nursing theories included, and then concluded with something that also speaks a lot to me, that nursing voices are not usually heard in many contexts, but also in telehealth. And then this is also an opportunity for us to be heard and demand that we set the standards and not the effectiveness of the companies or the technology that will set the standard, but our our opinion about how nursing practice should be that will guide the implementation of the technology. At least this is my understanding of what you, Patricia, said. But
Yeah.
this is also has to do with my experience from Norway or from Greece and nursing. And yeah, you might have said it in a different context, but it really meant a lot what you said about what you said. So thank you very much. I don't know if you have any comments, Pat and Rebecca.
I would say that in the U.S., our laws and regulations are always changing and updating, and so part of the barrier to utilizing telehealth is lack of regulation or regulations that prohibit use in certain contexts. So as we get better and better regulations and guidance from payers and from reimbursers and from state and federal laws, I think telehealth uptake will also be more popular and more readily available. But I do share Pat's concern that sometimes these regulations will prohibit the use in the very settings that we're talking about right now. So it is something that we need to be active in our policy role as well.
I see
Yeah,
Claudia. I'm sorry. Yeah, but Pat.
Yeah, I would just highlight once again that if we don't step up and we don't define what we believe our practice needs to be in this arena, in this environment, then we will no longer have control over it because this is happening very quickly. And I think it's long past time that we need to step in there and say, this is how nursing needs to be in this arena.
Okay, and I see that we have some comments from our colleague Claudia Bartz. I don't know if Claudia can speak because her microphone is open. Otherwise, I can read the message. Claudia, would you speak, please?
Oh, I didn't know my microphone was open.
Is that okay? Yeah.
Yes, I attended some of the World Health Assembly this last week, and one of the resolutions that was passed was that 2020 will be the year of the nurses and midwives. So that's good for us, and I know that IC and the Nursing Now movement are organizing many events around the year, and I'm sure each country will also take some responsibility for organizing recognition events. So we will try to do that in ISFTEH as well. Stay tuned for more. Thank you, Adolfo.
Well, okay, thank you, and congratulations for the year of nurses and midwives in 2020. All right. So, well, it's time to close the session. I just would like, once again, on behalf of the board of the ISFTH, to thank all of you for organizing this extraordinary webinar on telenursing. Thanks for the very special presentations. Thanks, Rebecca and Patricia. That was really outstanding. Thanks, Konstantinos, for organizing the conference, this webinar, and I hope to have the opportunity of your participation again in a series of webinars that ISFTH used to organize. So just to say that in this year, we are expecting 4 or 5 webinars. The first is planned to June the 27th about telecardiology. This is a webinar that we organized in conjunction with the European Association of Preventive Cardiology. You will be informed about this webinar and the next that will be organized through the ISFTH website. So I thank also Robert Ting, the IT expert that supports us in terms of technically running this kind of session. So thank you all very much and goodbye.